Good morning, colleagues in Europe. We are now 1 hour farther ahead versus our colleagues in the US. There might be some confusion and we might be losing some attendees potentially, and we are 1 hour closer to our colleagues in the East. So good day, everyone. It's the fourth day and last day of our kickoff Study-A-Thon. Just to remind you, this is an event that's only the beginning, and that we hope will leverage a lot of data, but also spin out many new studies that we will be doing in the future to help the community in this hour of a big pandemic and a big crisis internationally. Can I have the next slide, please? So yes, only 4 days or 3 days actually since we started this, and we have made a lot of progress. We're going to be giving you a quick update now with Patrick on the different streams and what we have been doing. You've probably noticed that my beard is growing and that my eyes are looking more shut every day, but it's been a joy to work with all of you, and it's been amazing to see so many people coming together and working crazy hours to pull this through. Next slide. So this is the slide that we show every day. This is the one from yesterday where we had just over 591,000 infectees with this disease and almost 27,000 deaths. Just a day later, if I get the next slide. Sorry, I think that's the one. Apologies for the technical glitch there. So one day later, we have more than 664,000 infections and over 30,000 deaths. And we have just heard the news of some colleagues who have relatives and friends who are affected by this disease. I also have very good friends of my own who are in the front line, battling and putting themselves at risk, seeing patients in let's say suboptimal conditions. So my heart and my feelings are with all of them, and I just want to take a second to make sure that we all honor them and thank them for their work. Next slide, please. Now, our work, there's been quite a lot of progress from South Korea. The colleagues from South Korea, as you know, converted and updated the claims and hospital EMR data, and they opened a call for analysis of South Korean data a couple of days ago. This is the hashtag if you want to mention them. And in the next slide, I just want to take time to remind you that there is a website that's open for anybody wanting to collaborate with our colleagues in South Korea and work with them to analyze their amazing data on COVID-19 infections in the South Korean regions. We will hear more about their progress later today, but I can reassure you that things are progressing very rapidly with the South Korean data. We are collaborating with them very closely. Next slide, please. Now, regarding estimation, which is the bit that I've been more involved with, I can reassure you that we are in a few hours going to have results of what's going to be the biggest study ever done on the safety of hydroxychloroquine. I'm sure many of you have heard the news that this drug is being now recommended for the prophylaxis and treatment of COVID-19. It is a drug that we use in clinics, often in rheumatological clinics, and a drug that has also been used as an anti-malarial in the past, that we believe has a good safety profile, but that nobody has had the opportunity to investigate at the depth we will have the opportunity to do here. We have some interesting findings that we will be sharing later today, but I am sure that by the end of the Study-A-Thon during our closed meeting, we will have completed the biggest study ever on the safety of hydroxychloroquine. Similarly, biological DMARDs are more novel medications that are not so often used because they are probably spared for patients with more severe spectrum rheumatoid arthritis and similar conditions. And again, we're going to have the biggest study ever done on the safety of these therapies And I think that is going to be very interesting and very informative for people who are considering taking or using these treatments for the prophylaxis or treatment of COVID. In the oven, we have a few analyses of the other big group of drugs that are being trialed for the treatment of COVID. And these are antivirals, antiretrovirals that we use typically for the treatment of HIV and hepatitis C. Again, these are going to be the biggest studies on the safety of these treatments ever done, and I am hopeful that we will have some findings by the end of today, and we will be sharing those with the community. Patrick, maybe if you go to the next slide and you want to take over and explain a bit about progress with the other streams.
Thanks, Danny. Yeah, so we've made tremendous progress over the last 8 hours in the areas of characterization and prediction. And I'll just highlight a couple areas that I think everybody should be excited about. Ed Byrne has been leading an effort to develop a standardized package for everybody to be able to run to characterize their COVID population and to benchmark that against the recent flu seasons as well as the H1N1 season. We have also now prepared a characterization that can run in the Atlas platform. So for anybody who has access to their OMOP CDM data in Atlas, I'll direct you to how you can look at that analysis. In addition, over the last 8 hours, we have fully prepared a study package to conduct 3 patient-level prediction studies. I'll show you where those analyses can be reviewed in Atlas, but I'll also point you to the Odyssey GitHub repository that contains the code for those of you who want to train any of these models. We've already actually begun the process of model fitting and have started to look at the preliminary results, which are extremely exciting. And so we're keen to see these models fit on databases, but also extremely keen to get to the next step, which is external validation of the prediction models we've created across the Odyssey network. So what I'd like to do is I'm going to toggle over to, let's see, here. Oops. Here. So the first thing that I'll highlight is in atlas.odyssey.org. This is, again, our production environment. I'm going to make that a little bit bigger so everybody can see it. For those of you who missed the update last night, we made tremendous progress yesterday over the course of the last several days in finalizing our cohort definitions that we are using as our target populations and our outcomes for both our characterization and estimation studies. For those of you who are interested in looking through those cohorts, you can see the 114 cohorts that have been created and are available for review on atlas.odyssey.org. But what's new in the last 8 hours, I think, is very exciting. We have prepared characterization studies that you can grab whatever group of cohorts you're interested in to evaluate within the Atlas platform in your environment. Specifically, there's a characterization that looks at your COVID-related target cohorts. There's a characterization that takes the benchmark flu years of 2014 to 2019, and there's also a characterization that looks at the H1N1 year of 2009 to 10. If I were to just click on here to look at what you'll be getting if you were to choose to execute this characterization package, what you'll see is that the characterization group did a great job of outlining 4 specific variants that they were interested in for target populations. There's a population of patients who are hospitalized with COVID-19. It is narrowly defined based on the explicit observation of a diagnosis code for COVID-19 or a positive measurement. But then we also broadened that definition to also capture suspected cases, as well as those patients who had fever and some constellation of either cough, myalgia, malaise, dyspnea, as a collection of symptoms that could potentially have been a case. By being able to characterize the narrow and broad populations, we can understand the baseline characteristics. In Atlas, if you choose to run this characterization package, the series of features that we've selected to generate as a standardized package include looking at drug use over the last year, as well as drug use in the last 30 days. We're going to look at diagnoses that were captured in the last 30 days, as well as the last year. We're going to compute the Charlson Index as a measure of comorbidity status. And then we have various demographics, including age, gender, as well as how much time patients were in the database prior to entering the cohort, and index month, so that we can actually track the number of cases over the months over time. In Atlas, if you were to import this package into your Atlas environment, you'll simply be able to click generate and run the results. And we hope many sites will, who have access to this, will choose to do that so you can explore the results yourself and share some of the findings that you learn. Much of what's being done in this characterization package is what we're excited to see happen as part of the standardized package that Ed and the team have been putting forth. But we think that this Atlas interface may be a great way for you to get started. The other thing that I'll highlight for you is in the patient level prediction scheme. You'll see that we have now published 3 prediction studies that are now ready for development. We've prepared these and reviewed them, and they're now been made live. We have 3 prediction questions that we're focused on. First is amongst patients presenting with flu symptoms, which of those patients are admitted to the hospital? The second is amongst patients who have a GP visit presenting with flu that's with and without pneumonia, but who are sent home to recover, which of those patients require hospitalization sometime later? And then the third question is amongst those patients who are hospitalized, which of those patients will require intensive services or die? These 3 prediction studies you can review them in Atlas and you can import them into your own Atlas environment. But already we have prepared a full study package at GitHub/Odyssey studies/COVID-19 prediction studies. Jenna has done an amazing job of actually preparing each of these 3 prediction studies as their own standalone package. And from here, you can actually grab this repository and see all of the work. So Jenna and Ross and Peter and the entire team have done an amazing job of making this available. What you'll see is that this one package is going to contain all of the models, all of the packages so that you can train a model, validate a model, or run existing models or simple risk scores. Right now, what's been posted in this link are the links to, if you are interested in training a model on your own data, you can take each of the 3 prediction problems and get to the link. You can also see for the problem of hospitalization, for those patients who are hospitalized, who are going to have more severe outcomes, we already have trained a model and it's available for external validation. So I encourage anybody who has data who's interested in training models on your own data to go ahead and download this package and try to see what you can learn. But also for those of you who'd like to apply models that have been learned elsewhere, this validation model that we're showing here showed extremely promising results on a US claims database. And we're eager to see how well it holds up when applied to the rest of the world. At our next update 8 hours from now, we're going to go into details about what these models have shown and what their performance is. But just to give those of you who are listening here a quick teaser, we're seeing tremendously interesting information across all 3 of these prediction problems. And suffice it to say, we think that we're going to be able to create models that are going to directly impact public health by providing real tools that can legitimately help providers and patients rationally make choices about how they should seek healthcare and which patients are most at risk. So we're excited to be able to share these work with you in our coming update and to think about together how we can disseminate these results and share it with the broader community. So as Danny said, today's our last day of this Study-A-Thon. It's certainly not the last day of this journey. I hope all of you have enjoyed these couple days of really getting closely collaborating with each other and getting focused on how we can do this. And I hope that you all feel as empowered as I do to recognize that this is just the start of a sustained effort that we can and should all do together to develop high quality evidence to inform this pandemic. Right now, we're having our update, and what we want to talk about is what's going to happen over the next 16 hours before we declare the Study-A-Thon complete and the start of the rest of the journey initiated. So with this update, we've given you a summary of where estimation has been, where characterization is, and where prediction is going. And our next update in 8 hours, which will be 11 a.m. Eastern Time, 4 p.m. in the UK, 5 p.m. in Central Eastern Time, Central European Time, and it'll be midnight in Korea. We're going to actually share our preliminary results and talk about what we're finding, hopefully with an encouragement to get more data partners on board with executing and sharing results, and we'll have another 8 hours to compile whatever findings we can. And our final closing today will be Sunday at 7 p.m. Eastern Time, which will actually be Monday, 1 a.m. in the UK, 2 a.m. for our colleagues in the Central European Time Zone. But this will be starting the day in Korea at 8 a.m. At this point, we were actually going to celebrate all of the work that we've done. We're going to share the final results and disseminate the findings from our characterization, estimation, and prediction studies. But probably most importantly, we're going to discuss our plans of how we're going to collaborate together as a community to move this journey forward and to bring evidence into the healthcare system where it belongs. On behalf of Danny, I want to thank everybody for all of their hard work. I've been so honored and excited to see how people have really come together for this shared purpose that we all have, and fighting hard to do what we can to stem the tide of this pandemic. Thank you all very much for your hard work. Thank you for pushing through this last final day, and let's do everything we can to generate the best quality evidence that we can to support the effort. With that, Danny, why don't we take some questions?
Yes, there's a good question actually waiting for us from Michael Schamberger. It says, how can the prediction models be applied at point of care by hospital staff?
Yeah, that's it. Danny, you want to take that, or you would like me to?
I'm happy to take it. I guess, Michael. So we are now working on seeing whether we can simplify these models by basically grouping features or concepts or conditions that look similar to see whether by doing that we lose performance or not. I think what we are doing nowadays in this crisis is we basically have like 2 points of care. One is usually a kind of phone call with some sort of healthcare professional who asks you a few questions and makes a decision based on, I guess, clinical intuition. And I think that model that Patrick was covering, one of the models that Patrick was explaining, will be very useful. If we can summarize it in a handful of questions, 10 or 20 questions, because that will inform much better decisions. And the second model, in hospital care, again in A&E, having something like this will be very useful. And actually, we are as clinicians increasingly used to using similar tools to make decisions in practice.
So we received another comment that the timings of the finale look like they're incorrect, and that is certainly plausible. I had to use a lot of time zone calculators to figure this out. We will post for sure, but the current thing I'm looking at suggests that is right. Specifically 7 a.m. Eastern Time. The reason that the UK and Central European Time, they just shifted over an hour last night, which is why now UK is 5 hours from the US and Central Eastern Time is 6 hours away, but that moved them 1 hour closer to Korea. So I think that this is correct, but if it is not, we will certainly correct it.
We'll double check, but it's going to be 7 p.m. EST. So if people want to do the math from there, they've made it a little bit complicated for us this last night.
To be clear, we worked backwards we wanted this to be 8 a.m. for Korea, and then we tried to work backwards from that. But no matter which direction you go around the world, it can be a little complicated.
Yeah, I guess this is more a comment than a question from Ed. He's saying, please see characterization channel. We're open to all contributions to the studies going forward beyond the Study-A-Thon. I might actually take 2 seconds to remind people that if you have been involved in any of the studies and have contributed to them, please make sure that you liaise with the study leads to make sure that you are named co-author and that you fulfill the criteria for that. I think I made this clear in the estimation channels yesterday, but maybe if you haven't discussed with the prediction or characterization teams, I think it's important that by the end of today, your name is where it should be and you have submitted your disclosures and everything so that we are in a position to wrap papers up when ready.
All right, Danny, I don't see any more questions, so I think it's you and I need to get back to work, as does everybody else. I want to thank everybody for their hard work. Look forward to these last 16 hours of the Study-A-Thon. Excited to see results in the next 8 hours, and looking forward to seeing all of you at the finale where we can share our findings.
Thank you.